Subcommittee on Human Services Resources. As a reminder, we have new meeting protocols in place for 2022 interim session. No remote attendance by members is permitted for the 2022 interim session. All members must attend in person to be recorded as present. The meeting material was put online earlier this week and made available for downloading. At this time, we'll have the Secretary call the roll.
Senator Rocky Adams. Senator Alvarado.
Here.
Senator Berg. Senator Carroll, Representative Bowling, Representative Fleming, Representative Frazier Gordon, here. Representative Gibbons Prunty,
here.
Representative Sheldon, Representative Weber,
present.
Representative Westrom, Representative Wilner,
Here.
Senator McDaniel, Representative Petrie, Representative Reed, Representative Moser, Co-Chair Bentley,
Here.
Chair Meredith.
Present. Next, we have approval of the minutes from the July 6th meeting. Do I hear a motion? Motion by Co-Chair, seconded by Senator Alvarado. All in favor say aye. All opposed say no. All opposed. Any opposition? All right. Minutes are approved. This morning we're going to hear from Nancy Galvani and Jim Musser with the Kentucky Hospital Association about a proposal for our outpatient HRIP, and we'll also have comments from the proposal from Steve Bechtel with the Department of Medicaid Services. So, you folks, good to see you again. You know the routine. If you would, make yourself comfortable, identify yourself for the record, and feel free to proceed.
Good morning. I'm Nancy Galvani, President of Kentucky Hospital Association.
Good morning. I'm Jim Musser. I'm the Senior Vice President for Policy and Government Relations at the Kentucky Hospital Association.
Before you folks start, I probably should mention that we had Nancy and Jim testify before our Medicaid Oversight Committee meeting, I think a couple of months ago, about this very subject. And what she's going to tell you today, extension of a program that we approved, I think session before last, and apparently it will require an appropriation, so that's why it's coming before this committee. So with that, please proceed.
All right. Well, again, good morning, Chairman Meredith, Chairman Bentley, and members of the committee. We want to thank you for having us here to talk about the Hospital Rate Improvement Program, which we refer to as ATRIP, which has been a highly successful program, and we want to talk about an expansion of that program today. So as you might recall, for those of you who were here in 2019, the General Assembly worked with us to pass the initial version of ATRIP, and then there was an important expansion in 2021. I want to say that the Cabinet for Health and Family Services, the Medicaid Department, have both been very wonderful partners working with us to implement this program and to gain CMS approval for its continuation. I want to express my sincere appreciation to the Secretary, the Medicaid Commissioner, and to Steve Bechtel and his staff for the excellent work that they have done and that they're continuing to do in support of this program. The ATRIP concept has been crucial for helping our hospitals stay open to serve patients during the pandemic, and it's providing resources for hospitals to seek to constantly improve the quality of care that we are delivering to our patients. In 2019, the General Assembly took a vital step to help the hospitals with the ongoing problem of financial stability when it passed Bam Carney's bill, which was House Bill 320. That was the original ATRIP program. And this program has no cost to the state treasury, and it allows hospitals to draw down federal funding so that Medicaid reimbursements for treating patients could be paid at the Medicare rate under the initial bill. So that was the first bill. And then ATRIP was expanded in 2021 to allow for reimbursement to be closer to the average commercial rate. And again, ATRIP doesn't cost the Commonwealth anything. It just allows the hospitals to draw on more federal funding to cover the cost of care that we provide to Medicaid patients. And it's also providing important resources for hospitals to improve quality. A portion of the payments that hospitals receive under this program are directly tied to an individual hospital's attainment of certain quality outcome measures. The program has to be reapproved annually by the federal government. Neither Medicare or Medicaid cover the full cost of care for our government-insured patients. And let me repeat that. Neither Medicare or Medicaid cover the full cost of treating patients, and I'm not talking about the charge for the treatment, I'm talking about the cost of the treatment. So ATRIP is critical because, as you can see in these slides here, 70 to 80% or more of the patients treated in our hospitals are covered by these two government programs. Hospitals simply can't continue to operate when 3/4 of the services that they deliver are paid below their cost to provide them. ATRIP helps to fill this gap, and it provides the financial stability for hospitals to pursue the quality measures that we all want. All of us are going to need the services of a hospital someday, so improving the quality of care is a universal need. Over the course of the last 2 years, we've also learned some important lessons from ATRIP. First, although the funds were not expected to sustain hospitals through an enormously costly shutdown of elective services due to the pandemic, ATRIP provided enough funding during the crisis to prevent hospital closures. And hospitals, contrary to what many people believe, did not make money from treating COVID patients. COVID patients spent longer times under care. They consumed a lot of services, a lot of PPE, and that meant that hospitals didn't have the ability to perform elective surgeries from which they derive most of their income. Second, we saw the need to expand ATRIP into the outpatient setting to assist rural hospitals. Today, hospitals receive supplemental ATRIP payments based on the number of Medicaid patients they treat on an inpatient basis. So since urban hospitals provide substantially more inpatient treatment, it's natural that about 65% of the ATRIP payments are being paid to urban hospitals. Since rural hospitals have a higher proportion of outpatient volume, rural hospitals are anticipated to receive about 60% of the benefit of expanding ATRIP to the outpatient setting. And while this wonderful program is currently helping all hospitals, it's clear that expanding the program to cover outpatient treatment would dramatically improve the prospects for our rural hospitals by helping to stabilize their finances and maintain access in all areas of the state. Once again, this financial stability for our rural health care would come at no cost to Kentucky's taxpayers. As with the current version of ATRIP, the hospitals would pay an assessment to the state to cover the state match, along with covering the administrative expenses of the program. And the timing on this expansion is very critical also, because the hospital's costs are skyrocketing. This slide shows that about 75% of the costs in a hospital fall into 3 categories: labor, drugs, and supplies. Like everyone in society, hospitals are feeling the effects of soaring inflation. This slide compares costs pre- and post-pandemic. Hospitals are not immune to the effect of inflation. They're some of the largest purchasers of food and energy, and they're being hit very hard by inflation. Labor costs have gone through the roof, and the cost of travel nurses alone has increased by more than 450%, going from $88 million in 2019 to $489 million today. Premium pay to retain nursing staff has also had a huge cost increase. Unlike Kroger and Amazon, hospitals in Kentucky can't simply raise their prices. With many hospitals, again, having patient census made up of 80% Medicare and Medicaid patients, those government programs dictate our reimbursement levels. We don't negotiate with Medicare and Medicaid. The losses that hospitals are incurring simply can't be passed on to commercial insurers. Most areas of the state have only 2 commercial plans, which cover 80% of all commercial enrollees. This gives insurers significant leverage in setting provider rates. Many hospitals, especially in rural parts of the state, have virtually no margin or even operate at a loss, and that isn't going to be sustainable. So while outpatient ATRIP isn't going to solve the problem of inflation or the soaring costs of agency nurses, it does provide a source of funding that's going to directly benefit our patients. So we're asking for you to please join us again as a partner in expanding the program through legislation so that we can draw down more federal funding. And should the federal government stop the program, this legislation would also ensure that the assessment to run the program also stops. Serving our patients is our guiding star, And the resources provided by the HRIP program will allow hospitals to constantly pursue improved quality of care, improve access to care in every part of the Commonwealth. So that's really what I wanted to cover today, but I'm happy to take any questions.
I'll start, Nancy. First, I appreciate your presentation as always. Your slide regarding inflation, we know that we've seen 40-year record high inflation, 9.5%, but I've been thinking for a lot of things we have within the healthcare environment are even higher than that. Do you have any specific inflation numbers for things like drugs?
Yeah, drugs was on the slide. We can pull that back up again. These are national numbers. It was very high, but one item that came up, I was at a meeting recently, they said the cost of rubber gloves, 240% increase. I think the next one had the drugs. So what does that look like? It's over 40%. That's, as you can see, the highest looking from February of 2020 to 2022. So you're right, it's, the overall cost, and, we can't control that. So, those 75% of our costs, it's your labor. You have to have your labor, and then you have to have your supplies. And so it makes it very difficult. And our rate increases from these federal programs, as you can see here, the Medicare program, haven't kept up with this. They're not keeping up with this.
Yes, I would suspect that probably the inflation rate specific to hospitals may be double, even triple than the 9% that we're hearing nationally. And
right.
I know it's quite a challenge. What's the number that you've given us previously about the lost revenue the hospitals had because of the shutdown and the inability to have?
So, yes, we measured it just in 2020, and we're still in the process of, looking at the CARES money, but we know that in 2020, the losses were $2.6 billion, and there was about $1 billion that was not covered by the CARES funding. Most of the CARES funding came out in 2020. There was like one other tranche that came out after that. So, we are way underwater. And I have had so many CEOs tell me from all across the state that they don't know what they would have done had we not had the HRIP program.
Yes,
But
I've
that's
heard
really kept
from
the doors open.
several facilities that it's truly has been their lifeline, but that's kind of letting them stabilize. But now we're being hit with this inflation. We've got to look at it as something different.
Right.
To that end, can you kind of give me a state of the nation type of summary of what percentage of hospitals are struggling financially?
This year is extremely bad because what we're seeing is an increase, and I hear this all the time, patients are sicker that are coming into our hospitals, so they need more care. We have this labor shortage that is, everyone is very worried about how we're going to be able to provide that care. Hospitals don't have the staff to even staff all of their beds, so we're very concerned about access. We're concerned about patient delays, and hospitals. We're watching this nationally, even that the revenues are not coming back. The revenues are not sustainable to the acuity level and the costs that we're providing. So hospitals, we're expecting to have a loss, and we're starting to hear that. We're starting to hear about layoffs in our own state. Hospitals that may be having to shut beds down. So we're seeing this across the country, and we're starting to hear about it here.
I think this will.
That's right. Yes, we didn't get any more CARES money. So if you think about 2020, that's when we measured these losses. Well, then, we had the Delta surge, which was the following year, 2021. We had Omicron. We didn't get any more money from the federal government. So, that money stabilized hospitals, but that money's gone. It's having to be paid back. And now we're having the surge in the labor costs. And so, we're not getting any more help from that. And so, again, HRIP has been what has helped keep the doors open in the hospitals.
I guess I'm looking long term as well. I see this as another stopgap, so to speak. I would hope that it would address the problems, but I'm not sure it addresses it long term for us. And has there been any discussion about maybe a different payment model for Medicaid that specifically reflects the difference between urban and rural? I know, urbans get kind of a bump up in their payments because the cost of living is higher in the urban areas than we see in rural, but there's some other factors that aren't taken into account. I have a great deal of interest in the deprivation index. It may be tying that to the payment model, but has your association had any discussion about we need to do something radically different?
Well, honestly, 90% of our patients are in managed care, and those rates are negotiated with the MCOs. So the cabinet doesn't dictate the payments anymore. Now most of the MCOs will just pay whatever the fee-for-service rate is, but I think that's kind of the issue, is that, technically DMS isn't telling what the MCOs have to pay. I think the MCOs have been good partners in HRIP, and I will say that when we do the HRIP, when that's an add-on, and every hospital is getting the same amount. That's one of the beauties of this program, is that urban and rural are getting the same add-on. It is not higher for urban than it is for rural hospitals, and so that's a big benefit for our rural hospitals. But and this is a value-based program. So, we talk a lot about, we need to move from fee-for-service. This program ties a portion of the payments. Hospitals will not get the money unless they show DMS and CMS certain outcome measures around quality. And so I think, this program is good in terms of, maybe setting the stage for doing more value-based payments, but we want hospitals to be successful in the measures that we're doing. We have excellent engagement of our hospitals around these quality measures. But I think, HRIP has filled that gap, but that is the concern, because this has to get approved from CMS every year, and there's no guarantee that CMS, just because they approved it last year, is going to approve it next year. And if that money were to go away, we would be in a world of hurt in Kentucky.
Understood. Senator Alvarado.
Thank you, Mr. Chairman. So I've got a series of questions just about the program in general. So this applies just to Medicaid payments, correct?
Correct.
So
Medicaid, yes, fee-for-service and managed care, but the majority is running through the MCOs because we're 90% managed care.
right, but these are federal dollars as a supplemental for Medicaid.
Yes.
They don't supplement Medicare.
No.
When you get the payment for this, let's say you get the successful payment and the supplement, is the payment you receive for this higher than what Medicare is paying when you add it all together?
It is. Medicare pays us less than cost. So the original HRIP took us from Medicaid base rates, which are very low, up to Medicare, but Medicare still pays below cost. And that's why we now have gotten approval to go closer to the commercial rate, which is higher than Medicare in our state.
So just to use an example of let's say if the cost is $100, Medicare is paying you $90, Medicaid's paying you $85, you get a supplement. How much are we talking about? Is it giving you an extra $20 to get you up to $105, $100? I mean, that's what a lot of commercial rates are. Is it somewhere along those rates?
It's going to be 90% of the commercial rate. It's not fully at the commercial rate, so it's going to be in that vicinity probably.
So it might get you to cost.
It's going to be over cost.
Over cost, okay.
But slightly over cost.
But it's better than Medicare,
It
which is sad, and that's only still
Yes.
29% of the pie.
That's right.
Right, half the pie is still Medicare that's
right.
underfunded.
That's right.
I remind people, a lot of people are pushing for single-payer systems, government-run systems. This is the garbage you got to deal with. VA medical centers, you talk to some of the patients there, see how that's run. A lot of it, and again, the underfunding of this stuff is the concern for a lot of these. Do you know how many states participate in this program that you're aware of?
Honestly, we are one of the leaders in this kind of a supplemental program. Now, a lot of states had them before, but then the feds changed the rules on it. And because in the past, states would just get the supplemental payments, and they wouldn't tie it necessarily to the amount of care being provided. They would just say XYZ hospital gets X amount, and it wasn't tied to anything. So, of course, we did not do that. We were one of the first states that came under the new federal rules. And CMS, I think, has supported our program because it's tied to patient care. So again, the hospitals only get this money. It's based upon the claims that they submit for care provided to Medicaid inpatients. So it's not just a made-up number. It's tied to the care that they're delivering. And so, there are more states that I think are following Kentucky's lead. I know we've had a number of states reach out to us and want to copy our program, but I think we are one of the leaders in the nation in how we're setting this up.
I suspect once you have enough states doing it, they'll change the rules again
that's
and find a
possible.
way to undercut. That's what
Yes,
happens. I
yes,
hate to say it, but that's the
yes.
reality of healthcare is, and if people have figured out a system that make it survive, let's get rid of it. This year we won't approve it. It would just be so much easier if they just said, hey, we'll just give you the extra money, and here you go, right? They're having to pay it anyway, but they just find ways of the shell game. Is there a cap on the overall amount of money that the feds allow for this program, or is it just it's an unlimited amount?
Well, I mean, we have to gather data, and Steve Bechtel's here, and he can probably talk about it. They're in the process right now of gathering the data from the hospitals on what the average commercial rate is. Again, we're going for 1% of that, so all that's going to be costed out in the documents that they have to submit to CMS. So CMS understands what the potential payout is for this.
But they don't have an overall cap. They don't say.
No, it's
okay.
based on utilization. So
Sure,
if
sure.
utilization goes up, the
need is
supplementals
there.
will go up. If it goes down, it will go down.
And you mentioned that it's dependent. One of my questions was it has to be approved annually by them, which is, again, the shell game. Once enough states catch on and start doing this, it'll shift again. What particular quality measures are they gauging you guys by? Is it HEDIS measures? Are they using?
No.
Okay.
So it's a hospital inpatient program, so they're hospital-based measures. And so, and we have them broken out by birth. There's some birthing measures in here. We worked closely with the cabinet to come up with, what we thought would move the needle. So some of them, they deal with reducing the readmission rate in our state among Medicaid patients. We're looking at sepsis, identification and prevention. We're looking at certain infections within the hospitals, CAUTI rates, C. diff rates, opioid prescribing. And then one of the things that we're going to be moving into, and we've kind of mapped out the measures over a number of years. And so basically hospitals, we look at what the state average is. And for some of these measures, if we don't have a baseline, then we spend the first year collecting the baseline data. And then we measure against what is the average. So hospitals get credit if they're better than average. Hospitals that are below average get credit if they've moved towards the average or they've reduced that gap between, their performance and what the average is. And so, we've scaled these to where, each year we're going to make them more aggressive because as a state, we want to, it's important that all the hospitals do better. And so CMS seems to like that approach. I know when we initially set a preprint in, we had suggested a 3-year approval. They said they wouldn't give us that, but we sent them the measures and showed them, how we plan to advance our quality metrics going forward. One of the things that we're going to start doing next year is measuring for social determinants of health and screening Medicaid inpatients for that and making referrals. So that's one of the things that we're working on this year, trying to get the processes in place of how we're going to be doing that. So, we're going to look at this program. We're going to look at what measures can we retire, what new measures need to be put in it. But again, it's a hospital-based program, so they have to be hospital-based measures, not measures in a doctor's office.
It's like an ACO model for hospitals, effectively, is what this is. You're starting to gain the data, set the baseline, show improvement from what your baseline was, not necessarily an overall baseline,
Right.
but here's your baseline. You show us
Yep.
improvement. We'll reward you.
Yep.
At some point, that eventually levels off. How many of our hospitals currently qualify for this? I mean, I'm sure some of them probably don't meet the measures. Do we have an idea of how many of our hospitals? I mean, not all of them are getting the supplemental payments, I would imagine, or are they all getting
Well, this
it right
is
now?
the first year that we're doing this. So in the very first year we got approved, it was COVID, so CMS didn't require that. But this is the first year where we're doing those measurements. And so I have a whole quality staff at KHA. The hospitals are using this money to engage in education. We're bringing experts in to say, you look like you need help in this area. So we have whole teams of people that are going in, pharmacists, infection preventionists, quality, experts going in, working with the hospitals in whatever area it is that they need assistance with. So that's where this funding is really going. Are they all there today? I mean, we only just looked at first quarter data, but, we think, I've never seen such engagement in the years that I've been at KHA in all the different offerings that we are providing to move the needle on quality.
Well, if it's a 20% increase on a third of your business, that's a lot of money. And for our hospitals who are struggling, it's a desperate need. So I'll be curious to see how this is an ACO model is what it is, effective from what you're describing. So they're just setting up the baseline for data. So we're going to see, everyone's going to get potentially an award early. And then I'll be curious to see how many hospitals maintain that.
Yeah.
And how we do. Thank you, Mr. Chairman. I appreciate your indulgence.
Thank you, sir. Representative Bentley, you have a question, comment?
Thank you, Mr. Chairman. Considering the nursing shortage, are you seeing an increase in malpractice because of the nursing shortage?
I've not heard about that, no. I can't say that we're seeing an increase.
I'm getting complaints from nurses that when the traveling nurses come in, there's not as much communication, or it's like cooking in someone else's kitchen. Or if you bring a nurse in, say she's from the Philippines and she can't speak English, that they're hanging bags wrong, and it's the regular nurses that are keeping everything from going to malpractice.
Well, I would say it certainly is a challenge to have as many travel nurses in our hospitals as we are having to rely on, because they're there for 13 weeks. You have to get them oriented. They may not be as invested in the quality work that we are doing, that the regular staff is doing. And then sometimes we have these traveling nurses that aren't really traveling. They actually, live down the street or used to be at the hospital across the street, but now they're a traveler. So it's kind of a mixed bag in what we're seeing. But we are concerned that we can't continue to keep relying on contract labor, because that doesn't support the quality processes that we're trying to put in place in our hospitals. But unfortunately, that's where we are today until we can, make inroads into addressing the workforce shortage, and there's no quick fix to that. We have a number of things that we're working on, with KCTCS, Council on Post-Secondary Education, the Chamber. In fact, we're going to be coming out with a workforce shortage report, kind of looking across the state. How many nurses are we short? How many other professionals are we short? Trying to work with education around what's the fastest way we can get more people trained. We're looking at apprenticeships. We're looking at every idea we can think of. But, that's going to take a couple years to, get people, out of any kind of training program, to be honest with you.
Thank you. I was just wondering about malpractice, if it went up because of the shortage. If you see anything like that, text me.
I'll be happy to let you know.
Thank you. Thank you.
Probably the litmus test on this will be the number of commercials you see on TV from plaintiffs' attorneys suggesting people call them. So we'll watch for that. But if there are no other questions for Nancy and Jim, we'll let them excuse themselves. Ask Steve Bechtel to come up to speak on this as well. But appreciate your presentation this morning as always. Thank you. Good morning.
Morning.
Didn't see you hiding behind the column there, Secretary. So,
Thank you.
you gentlemen have been here many times before. Always good to see you. If you would identify yourself for the record, and feel free to proceed.
Thank you, Eric Friedlander, Secretary of the Cabinet for Health and Family Services, and I couldn't let Steve come up on his own.
Steve Bechtel, Chief Financial Officer for the Department of Medicaid Services.
I would like to thank the Hospital Association. They've been really good partners with us. And around what Ms. Galvani was saying, we have, I think we are one of the only places in the country, and I do believe we are a leader in this program. Senator Alvarado, you are exactly right. As soon as it gets figured out, they'll change the rules, and we'll have to figure out what the new rules are and how we assist our providers in the new rule environment. I've seen it too many times, and I agree with you completely. But we'll do that. And the thing that I'm most excited about within this program, certainly, there are not many pieces of legislation that get passed and implemented, we'll take credit for the implementation, that save an industry. And I think this piece of legislation, I think Nancy said it, and I think it's fair to say, this really saved a lot of hospitals in Kentucky. The other piece that I want to just kind of expand on just a little bit, it's not, those of you who are old enough to remember Lake Wobegon, right? Every kid's above average. It kind of starts out that way, but here's what happens. The risk increases as the years go on. So if you don't meet X number of standards, you get less of this pie, right? I think that's the fair way to say that. So there's a risk base to this. And to the quality pieces that, and as Nancy said, we increased that over time. Actually, something else that I was really excited about within the cabinet that this allowed the opportunity to do is essentially, we have doctors that work for the cabinet, as you know, Dr. Stack's here. But we use this opportunity to form a medical staff within the cabinet. and taking the doctors who are from DCBS and Medicaid and the Commission for Children with Special Health Care Needs office, and bring them together to form a medical staff to review some of these proposed quality measures. And we really had a back and forth negotiation with the hospital association. It makes me worried that we're all happy with it. It means I didn't push hard enough, but we actually are all happy with it. And I'm particularly excited about getting baselines for Kentucky. Right? You asked about HEDIS measures, and the way I feel about HEDIS measures are great, but it's like cheating to the test. Right? Once you know how to get the HEDIS measures up, you do all those things that you can check the box and get the HEDIS measures up, and it really doesn't have any impact on quality. These measures really have to do with quality in Kentucky. So I'm excited about it. You did see the subterfuge of the ASO model. I appreciate that. But this is what, I think this is a really good model, actually, because, and it's actually easier to implement because of the MCOs, just because it's a directed payment and there's no need to go all the way down that, but it actually makes it a little easier. I'll also say Medicaid expansion was helpful because now more of these folks who come into the hospitals and get discharged and get the that's not a RAP payment, supplement directed payment. There have been so many different names. It's directed payment through the MCOs and through fee-for-service, mostly MCOs. It's triggered by that. So those are the big pieces. I know what they are. What the request is around outpatient and extending to outpatient. It will have more impact on rural facilities, and it will. It's another kind of big number. So we'll need we'll be happy to work with you all on what we size as an appropriate appropriation increase, how we may want to extend that, because the HRIP statute itself will have to be amended a little bit to account for an outpatient side. But I've said this to the Hospital Association. I believe I've said it to you all, probably in private, but I'll say it here. In many ways, what we pay Kentucky providers, as long as it doesn't cost Kentucky taxpayers, which is what this program does, right? The hospitals come up with a match. We should do that, right? We should be helping our Kentucky providers, and particularly if we can move them towards quality. And I think that's the challenge. That's the challenge we all have here, right? We're paying a lot of money in Medicaid. How are we moving towards quality? I am very interested to see if this program can help us do that. And if it does, and if it can, we should be modeling this type of program for other providers. How do we work with other providers to not put the burden on the Kentucky taxpayers, but where we can increase rates to what is appropriate and can drive quality? You can't ask for quality, right, if there's no funding for it. And this is a big incentive for quality, right? And the hospitals have been very engaged in this. It's like they say, it's been a lifesaver. And so it's just one of those areas, like Senate Bill 50 and the single PBM, where we are leading the country. And it's two examples right off the top. So as always, thank you for your partnership. Steve, did I steal everything?
Yeah, I don't know how I'm going to follow that. I will just say this: I take a lot of pride in working with the Kentucky Hospital Association. I think we're setting a standard for everyone on how to engage stakeholders and to get their input and to come to a common goal, common place. And that's what makes this so successful, is that we are working together versus against each other. And unfortunately, in state government, sometimes in federal government, you work against each other. But in this case, it has been a very open, transparent. We meet each week. We set out an hour each week on Wednesdays to meet with the KHA team. And they bring concerns those that they represent, and we try to address those concerns. Now, it's not just setting the payments; it's also looking at appeals, claims, things like that. But we do that in a collaborative effort, and it's been it's been a great experience for me. I will say Senator Meredith, you asked in your email or in the email I've received, what are our concerns? What do we need to implement this program? And it's very simple. We're going to need CMS approval, like everyone said. We have to get approval to add the outpatient. We have to get the approval for the next year. It ends so far. Right now, the program will end December 31st of this year, but we're already in the process of renewing for January 1 of 23. We just need to pull in the data, which I think we have just a few hospitals that we're still waiting on to get that data on the outpatient side, so that we can apply that toward this application and put it into the calculations and put it in our preprint request. The second thing is we're going to need legislative support. What that means, what I mean by that, we're going to, Secretary hit on it, we're going to need some changes to the statute as well as maybe some regulations. We're going to need y'all support on that, as well as for this committee here, we're going to need the appropriations. The budget appropriations. I know Ms. Galvani said that it's no cost to the state, and that's true. They pay the match, but I still need the restricted fund appropriations in order to make this payment happen, as well as federal fund appropriations. We do not know at this time, well, like I said, we're still gathering the data, what those appropriations will be just yet, but we will be bringing that to you all as soon as we have a good estimate. So those are the things that we need to implement and what will be necessary. The other thing is I just want to touch bases. Yes, other states have reached out to us. I work with I sit on a national CFO, Medicaid CFO affinity group where I meet with other states, and other states have asked me about sharing our preprint. Oklahoma was one of them. I think Florida was looking into it at one time. I'm not sure if Tom down in Florida, if he used it or not, but he was looking at it. So we are a leader there, but like Senator Alvarado and the Secretary have mentioned, if the more that they follow, the more that CMS will try to change the game on it. So, any questions that I may be able to answer?
Comments and questions. First, I do appreciate the comments and very pleased to learn of the relationship between the cabinet and our healthcare providers. And you all heard me say before that in my almost 40 years in healthcare, for many of it, it seemed like we were in an adversarial relationship and we shouldn't be. And I really sense a subtle paradigm shift that we talked about social determinants of health before, but we never have really directed policy to address those. It's like we're two different silos we're working from, and this is obviously moving in that direction, and would certainly like to see more than that. But see, when you're talking about legislation, obviously, I don't want to take it for granted, but we're talking about the 2023 session that we could move this forward.
Correct. Yeah, we are pushing to try to get this approved starting 1/1 of 23. Now, I understand we wouldn't make the first payment until after, because we pay it quarterly. So we would have to wait till the first quarter's over and then pull the data, and we wouldn't be making a payment until sometime probably mid-May. But we will need that authority to do that.
Well, with the inflationary pressures that don't seem to be subsiding at all, and I know this is really reaching for the stars, but there's not a possibility that we could include this legislation as part of the special session we have coming up in the next couple of weeks, can we?
I doubt it, and I'm not a part of any of those negotiations. I'm very pleased to say, and it wouldn't make any difference anyway, because I think really there's time. There would be time in the 23, and obviously we are not dictating to you all. You all will, you'll work with the hospital association more than us on that legislation.
Right.
And we'll provide the background. Of course, we'll provide the background information and support. But
Good.
I didn't mean to interrupt
Thank you.
you. But the other thing is I'd have to do the fiscal on that legislation, and I don't have the data yet to provide that.
don't have it for you.
All right. Representative Prunty, you have a question, comment?
More of a comment. Thank you, Mr. Chairman. It is kind of scary when when people are saying they agree. And I've seen firsthand recently when my parents were in the hospital that we had a shortage of nurses, and my mom's like, we need our hospital. And then the nurse in the ER was actually going to Louisville to be a traveling nurse to Louisville. So I see all this, and I'm very much about our rural hospitals. But it bothers me to say that Medicaid expansion helped because, to me, I think people need to be working and getting their commercial insurance and paying for it because Medicaid and Medicare dollars are taxpayer dollars. So it's just an observation. So thank you, Mr. Chairman.
Representative Wilner. Anyone else? Just a couple follow-up questions. First, tell me more about this Lake Wobegon.
Garrison Keeler on, anyway, I'm sure you know. Yeah, all children are above average in Lake Wobegon. I forget what the rest of the quote was. Dr. Stack told me and commented that we were both old enough to remember. So,
another comment you made that I was quite impressed by, your panel of doctors within the cabinet now, that you can really get them to agree on stuff, because that's just what my experience is.
Actually, yes. I think we're long overdue for getting that done.
Yeah.
And they had several years ago under Dr. Hacker, they had, who was a Commissioner of Public Health, kind of got together for lunches, right? But that's not the same thing as working on something. And so I feel like we have that expertise within the cabinet. We should access it. And and it's always better to try to do that when you have a project. And this gave the opportunity to have a project for them to work on together and make those recommendations. So I'm kind of excited about it.
Should be excellent. The only suggestion I have for you is you might want to add a hospital CEO to that mix just to kind of move things along quicker. But appreciate your testimony this morning, and very encouraging news, and looking forward to working with everyone to make this a reality. Any other questions, comments? If not, thank you for the presentation. I love you. Next, we'll have an update from Secretary Freelander. That's why he's remaining at the desk there. And Eric Lowry on where we stand with COVID-19 funding and the state received the past 2 years. And I'm glad to have Dr. Stack joining us as well. So, gentlemen, again, you know the routine. Identify yourself for the record and please proceed.
Eric Friedlander, Secretary of the Health and Family Services Cabinet.
Stephen Stack, Commissioner for Public Health.
Eric Lowry, Executive Director, Office of Finance and Budget.
Good to have you all. Please proceed.
Certainly. A couple of caveats before we begin. This funding is the funding that came to the cabinet. This is really not addressing overall state funding. This is only related to funding as it specifically flowed through the cabinet. So, given that caveat. Second caveat I want to give you all is this. And I know you asked questions about what I'm worried about, and we'll get there. We really tried to look at how this funding came in. When was the expiration? When was the expiration date on the grants? So what do we spend first? What can we use it for? We were trying to figure out what was most impactful, and acknowledging that we were all learning as we went. Absolutely. I think I've testified in front of either this committee or other committees that I've been in front of. We're going to spend the next 20 years figuring it out. I think this is going to be something that gets studied for years. What states did with their funding, how states responded, all sorts of things that are going to be looked at by many folks who are much smarter than me for many years to come. So I just kind of say that as kind of to caveat what we're talking about. So I just wanted to kind of give you all that sort of as a preamble. The other philosophical piece we were trying to do, which is this is mostly one-time funding, right? This is, or time-limited funding. There's not much there isn't anything in here that doesn't have an end date on it. The dangerous thing for us to do would be to set up ongoing programs so that I would come back to you in 24 or someone would come back to you in 24, 26 and say, we've got this gigantic hole. Okay, so those are all my caveats. With that, one of the things we at the Cabinet for Health and Family Services are really good at is spending money. And so we really have tried to make sure, because it feels like these go into communities. You heard some of the hospital, those funds that the hospitals got through some of the relief funds, paycheck relief, that's not in here. Actually, those direct payments to healthcare providers, which which or to industry. None of that is in here because it didn't flow through the cabinet. So again, just another caveat for everybody. So these bills and this funding, we wanted to give you some idea of what came in and where and how we spent some of this funding. So that's why Dr. Stack is here, because a vast majority of this funding flowed through his department. And it actually, I get my committees confused, so I apologize. But there's so much funding here that within the cabinet, Medicaid's the biggest, DCBS is next, and historically, behavioral health was next, and then public health. This is so much funding, it flipped those two. So public health ended up in this last budget as being the third largest department in the cabinet. So and in a big cabinet, it does take a lot to change that order. So again, just all those caveats. So these funds came in. All of these, and Eric, help me remember what all of these are because I get confused. The Preparedness and Response Supplemental Act, that is basically over.
Yes.
And so that was a lot of funding that went to help. Steve, do you remember which one this one is? I know, Eric, you do.
That was more towards public health.
That was public health. And some of the aging and independent response. So that was supporting local health departments and aging and independent living to make sure that we were providing meals. Aging and independent living and meals is one of the things that I will tell you that I'm worried about. I'm worried about three things. Meals is one. Some of that is one-time funding. So if the demand keeps the same across budget years, we will go back to waiting lists. We had waiting lists prior to this. We don't have waiting lists now, but this funding helped us not have waiting lists. So it was a big deal. And there's some one-time funding in the budget this year to help with meals. And so we'll continue to not have any waiting lists through this budget. We're very confident of that. But the next budget, there'll probably need to be some supplement there. The Families First, again, these are all the pieces that came through. Some of that economic security, that was some of the enhanced reimbursement for families. Think PEBT and some of those things that came through there. We had a little bit of the Payment Protection Act. Some of these other things that came through. I mean, we spent it on vaccines. We spent it on vaccine clinics. We spent it on IT solutions. We spent it on enhancing our ability to respond. We spent it on vaccines in schools. We spent it on PPE that we provided to healthcare. We had I don't mean to steal what you're going to say, Dr. Stack, but we went from a warehouse about this size to a warehouse about this size. We went from a maybe less than a week supply of PPE to now we have a supply of PPE that won't expire, that will be able to respond, and we use it to respond to things like floods and tornadoes. So it has come in as something that has beefed up our ability to respond to emergencies. So all of these pieces have come through. Some of these are longer than others. And you can see at this point, we have about, and I know this is like just a crazy number, but we have about $1 billion left to spend, but that's over the next couple of years. Actually goes out to 24. So there's a spread of this across, depending upon the grant, a couple of years. Next slide. So here's where it went. Again, you all heard, PEBT, SNAP, childcare. A lot of the funding went through community-based services, which was already the second biggest department in the cabinet, and then much more of it went out through Medicaid. Childcare, number 2. We have supplemented childcare with a lot of funds to support we now have grant programs for folks to open up small childcare. We have some matching grants for industry to open up childcare. We have some grants for childcare to assist with some capital facility improvement sorts of things. We've taken away co-pays. We've increased the percentage of folks who can participate in childcare to help folks get back to work. And so there's a lot that has been provided to childcare. When this ends, the next budget, there will be a need for additional childcare funds. We'll size that for you. We don't quite have it yet. We are working on it, but that's a real concern. Of all the concerns, right? The meals is not it's millions, right? So I don't want to downgrade that, but childcare is much more than that. That's going to be the biggest hole to fill, no question about it. And I think I believe we've spent funds in a way that helps people stay open. But as you saw with the hospitals, the cost of wages for individuals to go and actually provide care and childcare is probably, well, it's across industries, right? But childcare, it's particularly acute. How you are able to bring folks in who might otherwise be able to go to an Amazon or somebody else, right? That's a challenge. You want to see people get these early childhood education certificates. Again, that's a challenge. So you actually put more on folks in childcare. So while we didn't have as many childcare facilities closed as we were worried about in the beginning, many are still not operating at their licensed capacity just because they can't get staff. So I think moving forward, if I had to target a big area, that big area is childcare. So I know all sorts of discussions about how to do that, universal pre-K, however we want to do it. It's just know that coming up is probably a pretty big down payment there. And I just that's one of the ones, that's the biggest one I wanted to target for you. We spent a lot of money in public health, also with our labs and improving laboratory. The third thing that I would tell you that what the pandemic has revealed is we need a new laboratory. It's 15, 20 years old.
It's over 30 years old.
And healthcare, right? How much equipment do we use for 30 years in healthcare? And some of the equipment is really old, and the design is old, and the building is old, and was it designed perfectly when you learn more over 30 years. We should learn how to build a better lab, right? And we have, and a lot of people have. So that's a capital request that will be made. But there were three things for me. The third thing is I would say we have a desperate need for a new lab. Next, Eric. This just shows you we spent a lot on there's this piece that's substance abuse. There's a lot that went for community mental health. I think we're going to see some more of community mental health funding and mental health funding on the coming through the education bills, as well as there are more grants available to us based on some of the emergencies we've seen. So that's going to be the need ongoing. Is we know behavioral health needs. We're seeing it all over the place. Seeing it in schools, seeing it all across healthcare. I can tell you I'm seeing it in my cabinet, right? The folks that I work with, many of us are tired. And so it's been a flood, ice storm, COVID for a long time, monkeypox, avian flu, tornado, flood. I'm waiting for the locusts and the frogs. I hope we don't get them, but it's like, what else? And I don't want to say that. So you can see where the funding has gone. Again, a lot of that epidemiology and laboratory capacity, Eric. And again, this just breaks it down a little more for you. I don't want to quite go through it all, but the one thing I do want to note, which is really kind of not in the the overall pies that I've shown you is with the public health emergency, we do have an enhanced what is called FMAP rate, which is the federal rate in participation. So instead of paying, and I'm just going to use this as an example, Steve, don't get mad. Instead of like a 70% rate, we would get 76% rate through the public health emergency, and it's ongoing. And that's a chunk of change which helps save the Medicaid dollar. We're still waiting to see how long the public health emergency goes out, but that's really not in the figures, but you should know it's there as budget subcommittee. Next slide. Again, this just goes through where we spent specific dollars. I know this is an eye test, but if you all have any specific questions about, you can move on, Eric, because these are all eye tests. You can see, we try to break it down so you can see exactly where things went and what was spent. You all may go through this, thanks, Eric, and just, you may have other questions, right? It's just a lot to take in, and we're happy to come back at any time and go through these slides with you. We're just about, we've got another couple of acts, yeah. Like I say, if I went through all of these with you all, we'd be here until the next subcommittee hearing I'm supposed to testify at. So I hope this is helpful to you all. Again, we're just trying to show you where everything is. We wanted to make sure you could see where the expenditures are, and happy to answer any questions.
Well, first, I'll commend you for your approach to spending these funds. I think we've always had a concern that we would use them to build programs that there's no means to sustain them in the future, and your sensitivity to that is greatly appreciated. I can tell you, being co-chair of government contract review and reviewing all those, that's not the case with every cabinet, and we're starting to question those things right now, so I commend you. I think when you look at the total dollars you're speaking about in the elevation of public health, the expenses, I admit that's a concern to me, what happens post, because I think public health should stay elevated to that end. I've always professed that with our Medicaid dollars, if we improve the health of the population and move people to gainful employment, as Representative Prunty has said, there's dollars available to us right there for these other services that we have. But I don't think we've traditionally had that mindset. I see public health, Dr. Stack, as much as a potential revenue generator as it is an expense reduction. And I think there's an opportunities for that. If there's anything good that came out of COVID, it was the elevation and the importance of public health in our state. And I think we should build on that, and public health should take a stronger role, not just with our government programs, but within our society in total. How we do that, I'm not certain, but I think if we invest those dollars in public health, we're going to see return on them, and I think that's what we have to look at all of our tax dollars. So I appreciate your presentation and look forward to what we see in the future. Senator Carroll, you have a question?
Thank you, Mr. Chairman, and Mr. Secretary. Thank you for the presentation on the child care component of this. And it's good to hear that you all are gathering data on a plan for the future for this. Two questions. How are you all approaching that? Or as far as models on child care? And I ask that, as you're aware, the task force that we have, that's a large component of that. So my second question is, when will you have that prepared so we can have you testify before that task force?
We're working on that now. Eric, would you have any estimate? I know we're working on it with DCBS. They're looking at the difference between cover and copay, right? They're also looking at the difference between moving to 85% of average, median, all those initials, which is an increase, and what that difference is. The other piece that I think is probably not in here, but I think we should give you, is what's called the new market basket, right? Where we look at what the costs are, because I think wages have gone up, right? So we need to take a look at that. We're probably a couple of months away, is my best guess. At least, thanks, Eric. But I think we're probably a couple of months away, but we will get you that as soon as we have it.
And I would ask that you all kind of keep that in a broad picture. So for our purposes, as we start narrowing down, making policy from the legislative point of view, that this can be more of a collaboration with legislative and executive branch as we make those decisions. I don't think by any sense in that task force are we made any decisions in any way, or going in trying to be open-minded about all of it in the approaches, the mixed model approach. Not many fans of universal pre-K for various reasons, but everybody has the same goal: quality and making sure we have the facilities to provide sufficient quality child care across the whole state. So it's good to hear that. That's going to be valuable to our committee, and I appreciate you bringing that up today.
Certainly. The other thing that I think is really interesting, and it'll probably be ready to talk about not soon, but by the time the next budget's developed, House Bill 499, what's going on with that? For those of you that don't know, there's a fund that's set up, kind of a trust fund that's set up, that businesses can apply to help supplement the cost of childcare for their employees. And so we're looking at how to do that, and what does it look like our regular CCAP payment? I'm sorry to use initials. Does it look like a regular childcare payment model through DCBS? And then what would that look like, and how do you apply? And is it first come, first serve? There's a lot to work out, but I think that's a really interesting model, and appreciate that the General Assembly put funding in for that.
Agree. Thank you, sir. Thank you, Mr. Chairman.
Thank you. Representative Wilner.
Thank you, Mr. Chairman. Thank you for a great presentation and for the incredible work that you guys are doing under very dire circumstances for a long time. I hear the weight of the work you're doing. I hear it, I feel it, and I appreciate it. Want to echo the chairman's emphasis on public health and how important those investments are, and I'm really, like the chairman, really glad to see us moving in that direction, and I feel like that's going to have a tremendous benefit for Kentuckians in the long run. You mentioned school mental health, which is a huge passion of mine, and how do we treat our kids where they are and they're in school, and so how do we get the resources there? As we think about mental health resources moving into schools, will that still be within your cabinet, or does that move to education, or is that some sort of collaboration between silos? How do you envision that going?
It's got to be a collaboration, one. Two, there's an existing program around Medicaid that it funds some services, health services in schools. It was lifted off just immediately prior to COVID. And so we have some marketing to do with the school districts about what's available to them, because I think there's more available than they're taking advantage of. But we've had those conversations back and forth. There's the point of collaboration, the best point of collaboration, and you all know this, between CHFS and education is through the Family Resource Centers. They are heroes in a lot of this. I used to be over Family Resource Centers, and again, I've been over everything just about in the cabinet. But they're fantastic. And we're the only state in the country, again, another place where we are leading the nation in having these Family Resource Centers in almost every school in the Commonwealth. And so that collaboration among Family Resource Centers, sometimes local health departments, sometimes comprehensive care centers, school districts, school nurses, school behavioral health, all of those partners that can be brought to bear. That's how you start to bring more into the schools. And you all passed some funding for that. And so that will be a collaboration, and has been. Is that helpful?
It's very helpful and encouraging. Thank you.
One thing that both of you all raised about public health, and this is, again, a thank you to the General Assembly, but even through all of this, Representative Moser, had a public health transformation bill that went through the General Assembly a couple of years ago. That work has proceeded, and in the last budget, it was funded. So thank you for that, because part of what does public health do and what is the impact on local communities, a lot of that is tied up in the public health transformation piece about really paying more attention. I'm not going to do it justice, Dr. Stack. Paying more attention to community health, right, writ large, and making sure that that's what the local health departments focus on. The local health departments are just like everybody else. Some are better funded than others, and so there are challenges out there depending upon which, is it a single health department, is it a district health department, all of those things that are true. But I hope that, as you said, they feel far more valued, and far more as an important piece and understood than perhaps they have been in previous years.
Representative Prunty.
Thank you, Mr. Chairman, and thank you all for your presentation. I think maybe I misheard you, but on page 3 of your slides, or the third slide, I thought you said that a lot of the money went into Medicaid, but the percentage is 0%. Did
Right. That's because on a later slide, can you find that one, Eric? I wanted to make sure that it's on slide 5. Because it was hard to describe. And it's not as though more money went into Medicaid, but the change in the FMAP rate means that the amount of dollars that are not federal is actually less to get the same amount of revenue because the federal participation is increased. So that's why it's 0 there, but I didn't want to say it doesn't exist, because it does, and it's a big deal. But it's hard to define as more money coming, just because it's actually less money that needs to be used. Does that?
Yeah,
that's the best way I can do it.
And then just to follow up, Mr. Chair.
Well, sir.
This is kind of, I don't know if it's esoteric, but child care.
Mm-hmm.
It came to me that a couple years ago, I had a constituent ask me about a client. It was a hair salon, and she had a client who had child care paid for, and she was a stay-at-home mom on public assistance. Does the cabinet pay for child care for moms to stay home on public assistance, or? I just bring that to the floor because it was and I didn't know if it was true or not, but I just thought I would bring that today.
Child care is paid for folks who have, basically it's people who have jobs. Or there's education too, there's some education pieces with it, but that is 99.9% of it.
Yeah. But I think some of that was suspended during COVID for a period of time.
Mm-hmm.
Okay. Thank you, Mr. Chairman.
Thank you. I guess at this point I'm a little bit concerned about who we may have left behind, and that's not a criticism of anybody, but obviously crisis and points you in different directions, and very proud of what we've done for the hospital association. Looks like we've got it maybe on stable ground. I'm not sure we've made comparable efforts with our long-term care facilities, because they truly are in a financial crisis, and I'm not sure how we're going to address that, but it needs to be. But also, we've talked for years about the number of waiver slots that we have, and adult protective services, are they standing in the wings, and outpatient behavioral health that we really haven't given a lot of attention to. But I think that's something that collectively we need to give some consideration to, and try to identify what those priorities are for our next session, and obviously the next biannual budget, which will be here before we know it. But we've still got some weaknesses, and you folks are aware of that, but I think we need to truly be cognizant of that and give some attention to it. But I appreciate that COVID has kind of brought all of us together. It has pointed a lot of weaknesses within our social and medical infrastructure, and that's a good thing. We're trying to address those, but we've still got a lot of work to do as well. But Senator Alvarado, you have a comment, question?
Just one quick question. So I'm trying to, like you said, going through it's an eye test, going through all the numbers. And I know there's a lot of federal restrictions on CARES funds and that sort of thing. We're looking for a new lab. How much money would I'm looking at the CARES funds. We've got, almost $200 million in the epidemiology and laboratory capacity remaining. Is there no way we can use some of those funds redirected for a new lab, or would it require a waiver from the federal government to get that allotted, to be able to use those funds for that purpose? Because we talk about not wanting to use these funds for recurring expenses. A new lab would be a one-time investment, ultimately in medical infrastructure for the state that we could use. Is that not allowed to be used for that purpose, or can we?
Thanks, Senator. So CARES funding is over at this point, so that's all been expended and had to be expended or lost. CARES funding could have been used for a lab. ARPA funding is not yet is fully expended. That could be used for a lab, I believe. That would be allowable. The other grants, the CDC grants, cannot be used because they are allowable for very specific purposes under the CDC's parameters, and so they can't be used for major capital projects. And so they have attempted to make some additional funds available for some capital projects, but it's relatively small things. It's sort of $500,000, $500,000, $1 million, renovations for areas of labs, but it's not full construction of brand new properties and all.
So did we leave $340 million on the table from CARES funding? I'm looking at the chart from page number 9 that you guys have there, and this is Coronavirus Response Relief Supplemental Appropriation Act, right?
Oh, this only goes through the end of the fiscal year, so it goes through June. We have until October to fully. Do you want to finish that, Eric? Sorry.
So if you'll go back to slide 6, the coronavirus aid, relief, and economic security, this was specific to the CARES Act. The state received not only these awards to the existing programs we have, but the state also received the Coronavirus Relief Fund, the large part of money that the state could determine best way to respond to the pandemic, much like the State Fiscal Recovery Fund and the American Rescue Plan. Of that Coronavirus Relief Fund, the Cabinet received $319 million, which we fully expended. And those are the dollars that Dr. Stack is referring to.
So pull up slide number 9, if you don't mind.
Sure.
And it again meets Coronavirus Response Relief Supplemental Appropriation Act.
The CRISA Act. Yes.
Okay, so you got $257 million of an award there for epidemiology and lab capacity, and we've expended $61.6 million.
Mm-hmm.
So that it's almost not quite 200 million, but 195, something like that. Can we not use some of those funds for a lab?
No, sir. Those are the CDC grants that Dr. Stack was referring to, that a large capital project like that would not be an allowable cost.
Unless we get a waiver from the feds.
Yes.
So to put that in context, that grant, what the CDC and the other federal agencies did, they took existing grants that were already in place from different agencies and used those to really juice them up during the COVID response. So there is an existing underlying grant called CDC Expanding Lab Capacity, ELC, which is much smaller, in the magnitude of a couple $1 million over a couple year spending plan that's normally given to our lab or to our Kentucky Department for Public Health, and all the states get a grant of some sort. That was markedly expanded. The first tranche of that was largely spent on providing community-based testing when we did that in the very earlier days of the pandemic. The current money is for staff. A lot of that went to support local health departments for testing, also for IT system upgrades and improvements. But that's the specific pot of money I was referencing that the federal government has not demonstrated an interest or willingness in allowing you to use a massive chunk of money for a major capital project. They have historical restrictions on what they'll allow from those grants to be used for that kind of spending.
And I'm out of my lane here, but we couldn't do it until it was an approved piece in the capital budget as well. I mean, just that's the state process I'm talking about there.
And the distinction I was making, there are a lot of different, like Eric Lowry had mentioned, different specific funding sources for certain things. The CARES funding, the big CARES funding like that the legislature and the governor had, and the ARPA funding that the legislature and the governor have and work through that can support local jurisdictions, for infrastructure improvements, a variety of different things. That's more pluripotent, and that's obviously the remaining ARPA money that the legislature will determine in the next session how to use the last bit of that ARPA money. Those funds can be used for things like that, I believe. But these other grants, the ones I have, and this is a cabinet level lens on this, so I look at an agency kind of level lens. They have very specific grant deliverables for certain things that have to be done or certain things that can't be done. So, for example, we had a grant last year that was large, $134 million, to support COVID testing in K through 12 schools. very specific to that, could not be used for other purposes, and it was either use it for that or don't use it. And we expended probably about 96+% of that last year supporting K through 12 schools, and got out and provided well over 1 million tests across almost all. There were a couple of districts that chose not to participate, but almost every district. This year, there's just a little bit left. And so now we're providing antigen tests for the schools to be able to draw down against for as long as the money endures and the resources from the feds allow to support schools to have antigen tests this year. So it's different than last year, but there's still money being used, and we're confident we'll use up that $134 million before we reach the end of its spending authority for it. For the lab, if I can just real briefly comment on this, the laboratory is more than 30 years old, and part of the challenge when it was built, we didn't have laboratory technology like we do now. The new machines generate heat and humidity in ways that old technology did not. I just want to leave you with, because it will be some future commissioner who is the one who cuts the ribbon. It will not be me. It is a 5-year time frame from design to move in, and that's optimistic, and all of us have our skepticism about how efficiently those capital projects can move. And now we're talking the next biennium, so 1.5 to 2 years from now. It'll be 7 years down the road. The lab will be almost 40 years old. Every single newborn born in the Commonwealth has its newborn screening testing done there, 53 to 54,000 live births a year. There is no in-state alternative. It would have to be shipped out of state to a contracted lab at substantial added expense and delayed turnaround times. If we have white powder investigations, there's anthrax in the mail, someone thinks there's ricin or sarin or things like that, we have the only biosafety level 3 lab in the entire Commonwealth. There is no state alternative. It's one of only 200 such labs in the country. There are other things too, environmental testing, certain kinds of things that are provided to support people across the state. The water testing that'll be done in eastern Kentucky in the floods. Our state lab has a role in helping to coordinate or at least support some of that. And then, of course, other providers come in to augment when we need to. So for the next biennium, however it's funded, and it was proposed this last budget as a $135 million 30-year, I think, bond-funded, capital project. I just have to urge, it is a severe and very short-term operational threat to the Commonwealth that laboratory has already certain functions it cannot consistently maintain, like fine particle analysis for soils and other particles. We can't do that some days in the summer because the room cannot maintain proper temperature and humidity because it gets too hot in the building and there's inadequate environmental controls. So I urge your thoughtful consideration that there are many important needs in the state. That public health lab is an irreplaceable mission critical need, and I urge your consideration in 1.5 years when the next budget cycle comes up.
And what I didn't do a good job, and I think Senator Alvarado, this may help, and also Representative Prunty, this may help. If you go to that second slide, what we have listed there are the grants, the big grants, right? There's CARES, there's CRISA, there's the Consolidated Appropriate, all of these different big buckets of grants. The subsequent slides break each one of those big buckets down to the smaller ones. So Senator Alvarado, CARES, right? That's what Dr. Stack was referring to is 6 and 7. And then there's another, so then we head into another big bucket of grants. That is that Consolidated Response and Relief Supplemental, CRISA, right? I didn't do all of that because I should have, and I apologize. And I think that I probably added to your all's confusion, so I do apologize for that. But as you peruse this, that hopefully will help.
Ultimately, this is 109 different awards under 7 federal acts. There's a lot of information.
Have we approached our federal delegation about trying to loosen some of this up? That's what I'm doing right now on my phone. That's why I'm asking. I mean, really, if it's CDC grants and the federal government can come back in and say, yeah, you're going to allow it for this purpose. Have we tried that?
We've talked to our federal project officers, and we have regular dialogues I do with fellow state health officials around the country, and so far it has not been permitted for those uses.
Yeah, but how about the guys who can actually pull the trigger on a vote, which would be our senators and our congressmen? Have we tried that yet?
Not really.
Okay.
We haven't been in direct conversation
I'll try.
with them. Okay.
Thank you.
Thank you.
Well, you're here, certainly not a direct agenda item, but it has bearings on this since we're a budget review for human services, resources, and we are going to have a special session. We'd be remiss if we didn't talk a little bit about the floods in eastern Kentucky and what have you folks observed in terms of needs on staffing and infrastructure and any other needs that we may have to give consideration to.
I'll start and I'll let Dr. Stack continue. So we all know the Western Kentucky tornado and its impact, right? Many of you have seen, experienced. I will tell you that within the first day after the flooding in eastern Kentucky, in the Cabinet for Health and Family Services, we had more staff impacted. We had more individual offices impacted. We had more healthcare infrastructure impacted by these floods than we did with the tornado. It was a factor of 2 or 3. So this is a big event. I know those of you who know folks who reside in the impacted areas, they saw water in places they never saw water before, right? Somebody's home had been there 100 years and they'd never seen water and they got flooded. I'll also say this. I joke about frogs and locusts, right? But the continuous impact on staff, right? And the continuous impact on public health staff and the folks who are in that emergency operations center, they've been doing it again and again and again. I think they've been open more than they've been closed in 3 years. You can look into people's eyes. You can probably look into my eyes. You can probably look into Dr. Stack's eyes. We're tired. It's okay. We rise to the challenge, and we do. That's what we're supposed to do. But I would not be portraying impact on staff correctly if I didn't tell you it has had an impact and I can see it. I got a little more involved in this one than some of the other ones. It's not a reflection on Dr. Stack, but I felt like I needed to be closer to it, just because we're getting tired. I think though, to everyone's credit, our response was fast. Our response was impactful. If you know the Emergency Operations Center, and I'm going to get a little too deep, I think, but they're set up in basically what they call, what do you call those? Sections, yeah, emergency support functions. I think of them as sections. There's 1 through 14.
At least 14.
Yeah. So the public health response is called ESF 8. So, right, just a tiny bit of that. Director Slinker, who's going through like some of the first big ones in the transition from Director Dawson to Director Slinker, fantastic job. I have to say, fantastic job. But now we've done it 2, 3, 4 times. We're starting to get a rhythm down all its own in the emergency response. And the folks who have done it several times are working on that. We as a cabinet, in the ESF8 arena, we also have volunteerism, which helps with some of the volunteers. It's a different group. I think our response has been a little more coordinated and a little more comprehensive, but we can always do better. And that's the piece that I challenge my folks about. You asked about behavioral health. There's been a transition from through the years. We now embedded folks who were from the Department of Behavioral Health in with the ESF8. I think that's good. I think that'll have connections to comprehensive care centers and connection to longer term behavioral health supports that I think will pay benefits in the long run. And I think paid benefits to the staff that were sitting there. I think they were able to receive some not formal behavioral health support, but from folks who had a strong idea of what they were doing. I think we need to continue to build that. I had a meeting with Representative Bratcher yesterday and some fire chiefs about how we need to enhance that response, and we will, and we'll work on it together. I'm sorry, Dr. Stack. Dr. Stack's team, the public health team, has done response after response after response, big responses, small responses. How's the water testing? When can a restaurant open? Is the food that's being served safe? Are we doing disease monitoring in the shelters? All of those kinds of things that the staff is doing. Or do we, who's moving out of a healthcare facility? Does the hospital have potable water? All of these things, right? And they all have to do it at pace. I'm sorry, Dr. Stack, would you like to add some more?
Just a number of you have mentioned the importance of public health, and obviously I'm conflicted in this because I'm the Commissioner for Public Health, but I happen to agree with you. And I want to thank you. The investment that you made in public health transformation and support of House Bill 129 from 2020, and so you put in the tune of about $17 million a year and then $19 million a year each of the next 2 years in the next biennium, is essential because the health departments, when I started 2.5 years ago, had an attrition of workforce that over about 10 to 15 years, virtually all your local health departments sliced their workforce in half. And so there was a pronounced diminution in their capacity and their ability. That same little tiny workforce has been the one responding to COVID, to tornadoes, to floods, to monkeypox, all of those things, the Jif peanut butter recall, things like that, the infant formula shortage, that's all public health, all of that, in different elements. So your investments have made a huge difference. I will say your local health departments, I consider myself very privileged to serve alongside them. And I reached out to Senator Meredith when I was in his backyard visiting his territory, but next week I will have been to all 61 local health departments as of next Tuesday and 70-some counties to go to all the different health departments across the state. We regularly convene calls. I see them all as partners. There's no state or local. There's Kentucky Public Health collaborating through this. So I will back up to say my heart goes out to the people in Eastern Kentucky. So I went out there last week, and I went to Knott and Perry and Letcher and Breathitt and a couple others that we passed through briefly. It's very, very difficult to convey the devastation and the difficulty that communities face ahead to rebuild from this. I'll say at the cabinet level, it is an all-of-cabinet approach, and the secretary has been more visible. And I've had multiple people who have been in public health 15, 20 plus years who have never seen a previous secretary attend more of these emergency management meetings than Secretary Friedlander does. And to have that active support and partnership, to have behavioral health is now sitting side by side with the public health workers in the State Emergency Operations Center. And I will say, we haven't begun to scratch the surface there. All of us are hearing the critical need and a crying out for more behavioral health support, and are trying to find ways to match people who are in a time of need with the resources they need. And so Commissioner Morris and my colleagues at BDID work with us through all that stuff. So the investments you've made in public health are really invaluable. I think I worry about my team and their well-being because it is the same, every time we get a new task, a new project, it is the same small number of people who can only do certain things. But we are in a much better place than we were pre-COVID. We have used the resources you've seen on these slides to support public health across the state. Almost $130 million has gone out to local health departments to support their workforces and their needs over the 2020, 21, and 22 calendar years. We have really worked in partnership and open collaboration, trying to build teams. We've filled a lot of vacant spots, and we're trying to make sure they have the recognition and the support they need so that they can do important work supporting 4.5 million Kentuckians across our 120 counties, and trying to find ways to reflect back to our workforce that we all appreciate and value them, and provide the space and time some of them need to be able to step away from time to time to recharge, because it does take a toll. The people in Eastern Kentucky, the people in Western Kentucky with the tornadoes, their lives were upended. Many lost their lives. The disaster is not yet over for many. They are living it to the present time. The first responders and the caregivers who try to help those who are subjected to it also have their form of trauma that goes along with that. And that's very, very difficult too. And I think we need to attend to and try to make sure we're supporting the responders as well as supporting the people they're responding to help. But I want to thank you. Your health departments will make more investments in their future workforce if they have confidence the funding will continue. But they don't want to do the cliff approach that I think, Senator Meredith, you have rightly pointed out. They are wary to hire and bring on new staff to beef up the workforce if there's not clarity and comfort that there will be resources to maintain them. No one wants to go through a massive layoffs because the support for that dissipates. And what you've given is ample and is providing that ability and that hope that in the years ahead we'll be able to rebuild the public health and the public health system. And I hope that the health of the public will follow and improve in some ways with a more robust public health system.
Here, here. Appreciate that. Representative Wilner.
Thank you, Mr. Chairman, and thank you for this report. It's sobering, not surprising. So we saw in Western Kentucky that after the initial crisis, there was an ongoing huge need for continued behavioral health, mental health services. It seems entirely predictable that that's going to be the case in Eastern Kentucky as well. And Secretary Friedlander, we talked about this after Western Kentucky. How do we make sure that those resources are available for the community mental health centers, for others intervening, on the ground, the local comp care centers, to make sure that they have the resources they need in an ongoing way? And I just, for the members of this committee, I hope that when we do have our special session, we can make sure that those ongoing needs for mental health services will somehow be addressed in our appropriations.
I want to give you a little bit of a really good story about that. When the floods came through Eastern Kentucky, some of the folks who reached out and had provided support and counseling and crisis counseling services are the folks that came from Western Kentucky because they had just experienced it. So there's a lot of that, and a lot of those kind of stories of communities supporting communities, local health departments providing personnel to assist, who were going into these areas to help sister health departments and sister communities. So there are a lot of those stories, and I think it's really powerful about how we as Kentuckians, right, really do go out of our way to help each other, right, and that's what we should do.
Thank you for your presentation this morning. You made references a couple of times to the plague of frogs and locusts, and history is a great teacher. And if you remember, the reason those happen is because the leaders of the people wouldn't hear the word of God. Mm-hmm. So maybe if we pray, we won't have to worry about the frogs and locusts. But appreciate the presentation this morning, and looking forward to continuing our work together. Thank you. Have a blessed day. Before we adjourn, please be reminded that our next meeting is September 21st. With that, is there a motion to adjourn?
So moved.
Motion and a second. All those in favor, stand up and leave.
Yeah.
All those opposed, you can stay.
I have a constituent that reached out to me, and I've talked to Bentley about it, and he's supposed to email me